We move on to our last speaker for this session. He's Edward Hughes from Dartmouth-Hitchcock. He'll be talking to us about chromosomal abnormalities detected in clinical CMA testing of atypical melanocytic proliferation. He's also the winner of our second place Technologist Award for his abstract submission. And Dr. Min Fang from Seattle Cancer Care will be presenting him with his certificate and prize.
Hi, thank you for the award and the opportunity to present to you. I'm honored to receive, and I hope you enjoy the talk. So I'm going to talk about melanocytes and atypical melanocytic proliferations. So melanocytes can be found in various parts of the body, but for the purpose of this talk, I'll be talking about those that reside in the hair-bearing epidermis and the dermis. Neoplastic proliferations that arise from melanocytes can range from the benign through to the malignant, but it's those that we find in the middle subcategory of borderline that can be very interesting to us, because by some distance it's the most often misdiagnosed due to its inherent ambiguous morphology and histologic characterization. So, for example, under low UV exposure, a hair-bearing epidermis melanocytic proliferation may develop into a benign Spitz nevus, or indeed might progress all the way through to a Spitzoid melanoma. But indeed, it might be something in between in this borderline category, such as an atypical Spitz tumor. So Spitzoid and indeed other melanocytic proliferations can frequently have conflicting benign and malignant features on routine histopathologic examination. And classification into the correct subtype is by no means straightforward. Most melanocytes, or most melanomas indeed, can be distinguished from melanocytic nevi by light microscopy, and this still remains as a diagnostic gold standard. However, a subset of histologically ambiguous melanocytic neoplasms are diagnostically challenging for pathologists to classify and may result in misdiagnosis. Indecision can result in underdiagnosis as a nevus, or indeed overdiagnosis as a melanoma. And in turn, this can lead to unnecessary patient anxiety and unnecessary excessive cosmetic alterations for patients with relatively indolent or benign lesions. And I guess it's worthy of me to especially point out that amongst pathology subspecialties, dermatopathology is one of the most highly litigated due to misdiagnosis and subsequent mistreatment. And in addition, there is also a range of expert opinion in nomenclature and substantial disagreement in the criteria of classification into subtype. So it's our belief that additional molecular testing can provide diagnostic benefit for atypical melanocytic proliferations and hopefully help avoid misdiagnoses. One such test is the use of a SNP array, and this slide here I'm showing a couple of images that we can generate through Oncoscan. You are all aware of what a SNP array is, but just to hammer home the point, a benign lesion might represent, or might be represented by a copy number pattern such as the one here, and a malignant pattern might be represented by the image over here. So this graphic actually represents the accumulation of CNV data from all of our CNV reportable cases. So out of the 211 samples that we've tested, 131, or 62% of our cohorts, actually had no CNVs. Just to remind you, this cohort is of atypical melanocytic lesions. 74 of our cases, or 35%, did have at least one reportable CNV. Each row in this graphic represents a single case. Losses are in red and gains are in blue. Greens represent areas of LOH, and purple represents chromothripsis cause. Now, it's important to remember that most of our cases are presented to us due to some degree of uncertainty or desire by the pathologist to confirm a diagnosis of an ambiguous proliferation. We are mostly using Oncoscan as a diagnostic aid. It's not in itself a standalone frontline test. So for me right now, there are two goals for our use of Oncoscan in this presentation. First, we just want to share our experience in the use of Oncoscan to aid in the diagnosis of these atypical proliferations. The matter of the fact is that not too many institutions will offer this for dermatologic patient care. Second, I thought we could highlight some of the more common CNV abnormalities that occur in atypical presentations, and perhaps we can extrapolate some significance from them to aid in future patient diagnoses. So the first and perhaps most obvious use of Oncoscan I can talk about is its use in helping to identify malignant melanomas from atypical presentations. So it's been published, and it's quite well known that most invasive melanomas have chromosomal copy number aberrations, frequently involving multiple chromosomes. And with rare exceptions, such anomalies are not found in the more benign melanocytic nevi. So out of our cohort of 211 cases, 11 of these atypical melanocytic proliferations were diagnosed eventually as invasive malignant melanoma. And from this graphic here, you can see with just a single exception, most of these did involve entire arms of chromosomes in keeping with melanoma. The monoaberration case, highlighted by this green box, exhibited a single important gain of distal 6p, which includes the RREB1 gene, which is well described in melanomas. And again, in each case, the indication for study was an atypical melanocytic proliferation. So in our battery of tests that we might want to use, we can say that Oncoscan can be used to assess the prevalence of genome CNV aberrations, and in tandem with the histopathologic findings, can be used to diagnose malignant melanoma from an atypical presentation. So the next, did I go to? Yeah, sorry. The next type of lesion I'll talk about will be the Spitzoid lesions. And these represent a subclass of melanocytic lesions with distinctive cytomorphology and architectural findings, and do include the benign Spitz nevi, an atypical category including the atypical Spitz tumors, and the malignant category of Spitzoid melanomas. Accurate classification of Spitzoid lesions is challenging, and there is considerable inter-observer variability even amongst experts. Benign Spitz nevi and other types of Spitzoid proliferations also harbor distinctive copy number changes relative to ordinary melanocytic nevi, such as the 11p gain, whereas the atypical Spitz tumors and Spitzoid melanomas do indeed have copy number changes that are in keeping with conventional melanoma. But still, we believe, is within this space that we can use Oncoscan to help identify some of the more distinctive copy number abnormalities associated with either a benign or indeed one of these other subtypes, and hopefully provide additional valuable diagnostic information. Within our cohort of cases, 67 of them were assessed to confirm Spitzoid, 31 of which actually had reportable Oncoscan findings. So this graphic shows the 31 patients diagnosed as Spitzoid lesion with reportable CNVs. The majority of Spitz nevi, it is known that the majority of Spitz nevi, not necessarily this cohort alone, but in general, will have a normal chromosomal complement, while about a quarter of cases will tend to have chromosome 11p gain. And in our cohort, we indeed found 9 patients did contain the characteristic 11p gain, indicating that these were likely the benign Spitz nevi, or indeed a different type of benign Spitzoid proliferation. The remaining 22 cases had CNVs other than the 11p gain. So this would indicate to us that they would at least be diagnosed as an atypical Spitz tumor, for which the common treatment would be a conservative re-excision of the area. However, with further diagnostic testing, we found that 2 of these 22 additional patients were eventually diagnosed with malignant Spitzoid melanoma. So, as I mentioned, one of the uses of Oncoscan we wanted to highlight was that we can group together commonly occurring CNVs, and in doing so, it might be possible to pass out some additional observations between the type of CNV and the given diagnoses. And we found the most commonly occurring CNVs in these atypical melanocytic proliferations, including 1p loss, 6q loss, either whole chromosome 9 or partial chromosome 9p loss, as I mentioned, the 11p gains, and this rather interesting group here of 15 gain, or a 15q gain. So by far, one of the more interesting observations that we made by grouping together the common CNVs is that within the last few years, we actually encountered about 10 cases with a chromosome 15 gain, 7 of which it was the sole abnormality. These monoaberration patients are usually diagnosed as benign, but similar to the more well-known 11p gain in the Spitzoid category I just discussed, we think this aberration is actually most likely related to the pathogenesis of these melanocytic lesions, as they do tend to have histologic similarities. To the best of our knowledge, it's not really been described in the literature appropriately, and it's possibly something we might follow up. Due to time constraints, I'm not really going to talk too much about these other abnormalities, apart from the very important fact that we find when there's a 6q loss or a chromosome 9 loss or partial loss, that they tend to be diagnosed as a malignant melanoma when they're in tandem with 2 or 3, at least 2 or 3 additional CNVs. And the importance of a 1p loss that we've found is that it is only when it's present with a 6q loss or a chromosome 9 loss that a patient would have tended to be diagnosed as malignant melanoma, but a 1p loss without either of these other additional losses actually tended to have a non-melanoma, malignant melanoma diagnosis. So I'll finish up the talk by actually giving you a case study, an interesting case study to demonstrate how we would use Oncoscan successfully as a diagnostic companion test in aiding the decision-making for treatment options for a patient. So for this patient, the indication for study, or the reason for referral, is a 39-year-old male with a mitotically active atypical melanocytic proliferation arising in association with a cellular Blue Nevus. The highlighted regions here will get a close-up view next. So the histopathologic assessment of this lesion took place, and it was eventually given the assessment of an atypical Blue Nevus with these descriptors here in the slide. The ambiguous nature of this finding, of this assessment, is what I'm trying to highlight here. Really, with the histopathologic review, there really wasn't much to suggest that much of anything was going on, but it was enough to nudge the pathologist to want to explore other diagnostic options. So if we just have a very crude patient care decision tree, with an atypical Blue Nevus being the histopathologic assessment, if no further testing was believed to be required, then the usual treatment option would be a conservative re-excision. And not so long ago, it could conceivably have happened this way. For this patient and others, it could represent a cosmetic alteration for the patient. However, we do have the option of additional molecular testing to help us define the exact nature of the lesion, and so Oncoscan was performed. Significantly with Oncoscan, we did find the 1p loss I described in tandem with the 6q loss, with additional CNVs present, as described in this graphic, gains in 17q, 8q, 1q, and a loss in 18p. With these other multiple whole-arm CNVs, we would consider malignancy in this atypical melanocytic proliferation. But during our due diligence for these kind of cases, we do, as a team, do literature searches to identify other instances similar to our case, in this one, the malignant Blue Nevus actually refers to a rare and heterogeneous group of melanomas that arise in several clinical settings. Malignant Blue Nevus is a heterogeneous group of melanomas that are highly aggressive and often lethal, with a propensity for metastasis to lymph nodes and lungs. Digging a bit deeper into these articles, we can see a remarkable similarity to the CNVs described in the literature compared to our case, and these similarities are highlighted in yellow and orange. So if we go back to the patient care decision tree, as you can imagine, the prognosis and treatment plan dramatically changed for this patient. So after doing the Oncoscan and finding additional CNVs, this patient did undergo additional imaging, and regrettably, we did find evidence of spread to lymph nodes for this patient. So that would be my talk. I'd just like to acknowledge all the team back at Dartmouth who have helped me, and the wonderful dermatology department that we have there in championing the use of molecular testing in their patient care treatment plans. Thank you.